Hello and welcome to CanWaCH's learning series, co-hosted today and led by Miriam Nkangu and Patrick Okwin, joining us from Cameroon to tell us about their BornFyne Project, which is supported by Grand Challenges Canada, funded by the Government of Canada and Global Affairs Canada, and implemented in Cameroon by the WHO Collaborating Center for Knowledge Translation and Health Technology Assessment and Health Equity at the University of Ottawa in collaboration with Effective Base Services, eBASE, Cameroon, and the Ministry of Public Health at the district level in Cameroon. For some background on the expert guest that we have with us today, we have Miriam Nkangu, who is a PhD candidate in epidemiology at the University of Ottawa, who is interested in reproductive maternal newborn child health with over 6 years of experience working with rural communities on maternal newborn child health. She is a Grand Challenges Canada innovator, leading the BornFyne Project team with research interests in cyber health, evidence synthesis, and implementation. We are also joined today by Dr. Patrick Okwin, who is the District Medical Officer of Bali in Cameroon and the team lead of Effective Basic Services, eBASE Africa. Passionate about using innovation and best practices to improve livelihoods, especially for underserved populations. We are also joined by Janet Hatcher-Roberts, one of the co-principal investigators with the WHO Collaborating Center for the project. I'm now going to turn the mic over to our guests who will be walking us through today on an exciting two-part session. However, this part, which will speak to their experience on geospatial data, randomized control trials, and mobile applications. Over to you, Patrick and Miriam.
Thank you. And before I begin, I also want to acknowledge Dr. Sani Yaya on this project, who is also part of the principal investigator. So this session will focus more on data and programmatic strategies, data for mHealth project, which is BornFyne, and the RCT slide. So the learning objective today will increase awareness on reproductive maternal newborn child health situation in Cameroon. We understand the role of geographic information system in decision-making, understand data and programmatic strategies, and then we learn more how we can synergize BornFyne and the district health information system. So, slide. BornFyne is a local branded name in Cameroon, which means safe delivery. And it is interesting to note that this name BornFyne is used in Nigeria and in Ghana. They speak the same local pidgin English, and it means the same thing. This project is funded by Grand Challenge Canada. So I will leave the slide and Patrick will come in and Janet at any point to add value to it. So I will give you a little bit of background, contextual problems about Cameroon. So maternal mortality is still high in Cameroon with impeding access and utilization, especially antenatal care and skilled delivery. These issues range from high out-of-pocket expenses, poor referral systems, absence of emergency services, and long trekking distances. For example, as you can see on that slide, how I'm personally tracing the 2 hours trekking distance that some of these women experience during pregnancy. This is the time they cover just to gain access to motorable road before they can see any means of transportation to get to the nearest health facility. As you can see, I could not cross that bridge all by myself. I needed a helping hand from the community health worker that accompanied me, then talk less of a pregnant woman. So these are some of the practical day-to-day challenges faced by these women, especially in such remote rural areas. So our BornFyne slide, our BornFyne objective is to increase access and utilization of antenatal care and skilled birth delivery using e-vouchers, that's electronic vouchers, and also to enhance utilization of mHealth and communication amongst non-literate groups using graphics. and to improve access to emergency services, especially during pregnancy, and increase family planning awareness, and to empower women in making informed choices. So it designed the BornFyne mobile application. It has use online web-based platform called the Prenatal Management System. Women can communicate with providers once they enroll into the BornFyne by simply touching on the appropriate icon. So for example, if a woman is in distress and is unable to call or read, he touches the emergency icon, it alerts the provider. And using geographic information system and geolocalization, the provider and a transporter can be able to reach out to the woman in a timely fashion. And the provider on the other end at the health center will be ready to receive the woman. This saves time, especially in situations like urgent care. It is also important to note that BornFyne has other activities. For example, you can see from the slide some red tabs, how highlighted some of the online data looks like. Those are situations to inform the provider that this patient is having some problems. For example, the BornFyne can flag your history during pregnancy if you are like a high-risk pregnant patient. So that based on the data that is entered for your history, it's easier for the provider and the district officer to view the history of a woman and save it for continuity of care. And important for the district medical officer, he can see the activities of all his providers for each patient, but the providers can only view the history of the woman that they are treating. So another important thing about BornFyne is that you have family planning messages that are audio recorded and they listen in different languages, specifically local dialects. And these messages are developed based on communities' needs. So we go through focus group discussions and key informant interview in order to update the messages, so to tailor it to their needs. Slide. So before implementation of our intervention, one of our data strategy was to do SARA. SARA is Service Availability and Readiness Assessment. So it's a tool developed by WHO. So we adapt it to the context of Cameroon. So this is to ensure that all the health facilities are of the same quality and ready to receive the intervention. For example, we need to know and be sure that a facility has computers, and if they have computers, are they functioning? We also want to know facilities that have generators, and if the generators are functioning. And we also collect GPS coordinates. So as you can see, all those red balloons, especially on the first part of the picture, it shows that these are the location of health facilities. So each time a data collector is in the field collecting data, it automatically pop-ups this balloon when we pull out the data. One interesting aspect of this geospatial collection of data using MACPA is that it's very informative for a policy maker. For example, if you look at the second picture below, this one we are collecting data on if a woman is sleeping on a mosquito net. So all their responses, you can be able to see it, which means when you look at the data and you want to get more information behind their responses, you just click on the balloon and the balloon now can tell you, for example, I can read one. I was given a bed net, but never told how to use it. So that is already telling the policymaker the community need and how to address them. So this is further information when you use MACPA to collect data like this. It enriches your data and it gives you more further information to help decision makers. Slide. So we use other strategies like focus group discussion, stakeholder meetings. I would like to specify one important thing that we experience, which is a good strategy. During our stakeholder meeting, we are targeting very poor and vulnerable population. So we already identify very remote rural areas using equity scores. But we were challenged with one question during stakeholder meeting, that how can we come in an area that is very poor and we say we want to select the poor to enroll in the intervention. So they asked us, how are we going to differentiate who is poor and who is not poor in an area that they know that everybody is poor? So that was a very interesting question. And we had already envisaged something like that, because that is already the problem, targeting those who really need the services. So what we did through our focus group discussion, we now throw those questions to them, and then we ask the community to develop some set of conditions or criteria that within that specific context, they can tell that this woman or this family is poor or is in need of services, and how they would define poor and vulnerable in their context. So it is based on those responses that we put the data together and then develop a criteria, and then we did some kind of member check-in with them and then confirm before we use in enrolling the participants. So that was very interesting to us at that point in time. We also do a lot of community health worker weekly monitoring, and also we do a lot of data collectors collecting data at different time points. Slide. So before we go to the next slide, I would like to throw light on our randomized control trial. So the first part of it was the informative study. It informed a little bit, the slide before, it informed a little bit the intervention, and then this randomized control trial is a 2-arm parallel design, and we have the intervention group and the control group, the slide before. And we have 4 clusters. So the 2 groups, you have intervention and control. So 4 clusters. Clusters here are made up of health areas. So the randomization was at the level of health areas. And then the district now was a purposeful selection, because like I earlier said, we have to be, it's a proof of concept. You want to be strategic, and you want to, if a district medical doesn't give their accord for you to implement it in the district, there is no need. So you want to start with a district that is ready to receive the intervention. So district selection was purposeful for that purpose. And then also at some point, because of the political crisis, you want to also be careful which district you are enrolling at that point. And then the randomization now at the level of health areas. So we have our outcomes for the, so this is the feasibility studies. And so most often in the feasibility studies, you have feasibility outcomes. And because we are talking about program and data strategies, we had different outcomes for feasibility studies. So you can see that we have clinical outcomes, operational outcomes, where we are looking at the feasibility of resources, equipment, and cost for a larger trial, to inform a larger trial. So whatever thing we do now is a feasibility outcome. If we want to scale up the RCT, we have a better platform and understanding of our variables. So I will now invite Patrick to discuss about how BornFyne has been able to synergize with the district health information system to improve the quality of maternal and child health.
Okay, so we were able to find a very strategic synergy between BornFyne and DHIS2 data. So DHIS2 is a platform that's used globally for collecting health outcomes in health systems. And in Cameroon, we also use this. Improved DHIS2 data, that means data that's collected quickly and completely, facilitates rapid response on BornFyne, while BornFyne, on the other end, improves the intrinsic quality of DHIS2 outcomes. Now, this means that while we are collecting the data in DHIS2, it informs us in BornFyne that we are either improving or we are not improving on certain health outcomes. And we can quickly adjust or make decisions as per what health areas do we need to pay more focus or more attention to, and where do we need less attention. And because we needed this data for BornFyne, we had to work hard with the district health staff to ensure that they collect this data promptly and completely. BornFyne facilitates referrals in early pregnancy, thereby improving the quality and data, and if data is and provide making data available if it's needed for evidence quickly. DHIS2 can also be used to evaluate impact of BornFyne, and this was a very good, interesting discovery that we made in the fragile setting where we found ourselves in. So at certain point, it was not possible for us to go to the field, but because as data collectors that you send to a new community to collect data, they could get into harm's way. So the DHIS2 data is actually collected by healthcare workers and community health workers who are based in that community. So even when there is trouble, there would still be some people left behind who will be uploading this data to the system. And by this way, we can actually go and compare health areas where we were not intervening versus health areas we were intervening in from the DHIS2 data platform. Now, the connection between DHIS2 and BornFyne was done collaboratively by the Ministry of Health and the Effective Basic Service team. And normally, everybody would not have access to this data. You would need to get an account, and they will give you a password, and then you will be able to access it. But in this particular program, we were lucky to be able to create a collaboration with the ministry to have access to this data, and we can actually use it to evaluate the impact of our project. On this slide, we wanted to share with you how powerful bringing in a project like BornFyne could contribute to the health system performance in general. So this slide actually shows you the health districts in Cameroon that are in the current conflict area, the fragile area. And we can see that data collection has been impossible in quite a lot of them, very little in most of them. And in the green ones, where you have above 90% data completeness and for global health outcomes, prevention of mother-to-child transmission, voluntary counseling and testing, and drugs dispensation. Bali District Hospital, which is actually implementing BornFyne, is actually still able to collect all its data and on time. This was mostly thanks to the fact that BornFyne facilitates remoteness of services. And when this data was actually presented at the regional level, Bali Health District was called up to really share their experiences as to how they managed to get these results in and on time. And we shared the experience of BornFyne. And in presence were the implementers of the performance-based financing, which is a project that is funded by the World Bank. And they were very eager to come in to support so that other health districts or other health areas could be able to use this platform to remotely manage their healthcare services. This also shows you the potentials of BornFyne to be able to integrate in the health system, empower the rest of the health system, and be able to improve the global performance of the healthcare system. We would also like to talk about ethics and security for the users, for users' data online, because this is very important for us. We collect data from patients, and this data is used within an online platform, meaning that anyone could be able to access this data and use it for profit or for other intentions. So what we have done with BornFyne is that we store the data behind a password-protected account. Excuse. And every clinician has access only to his own patients. And the patients have a code. They could go online and view their health records. and only someone who has that code will be able to access their records. This means that they could decide to change their clinician and go to another clinician, and all they will need to do is just give that code and the clinician can take over their care. Also, any data that is made available publicly for any reasons, like in this research, will be anonymous and it will bear no links to the individual. We also use a secure host. For example, our servers are based in Africa and they are linked directly using satellite. This is very important to use satellite because 4G connection is usually manipulated sometimes by governments or warring factions. Sometimes government will insist that all gunshot injuries should be reported to the military. And if we do this, it would not be ethical. So if you are on a 4G network, there's the possibility that the government can access it and then use it for other purposes. We also comply with the Horn Code principles. The Horn Code principles expect us to follow certain standards with respect to using the data of humans online. This includes that we cannot share their data to advertising companies, especially, and also to government or any other actor that could have specific interest, selfish interest in particular. Miriam?
Okay, so I'll
go ahead.
Okay, so I will give you our contact details for this, and if you want more information, especially regarding the randomized control trial, we can better discuss about that. So our website, you have it on this, and the email address and our Twitter handle for the BornFyne, and then you can find the website for effective basic services as well, the email address and the Twitter handle, as well as a link to the video for a geospatial activity that was done in one of the projects. And we would like to thank our partners again. And so we would like to thank the Donwell System, which is the app developer for the BornFyne project. We would like to thank YEMS Group, which is the graphic designer, and Orange Cameroon, and the Ministry of Public Health, that's MinSante, and then World Solar Fund, which is supporting us with solar chargers. And final thank you to Grand Challenge Canada for this support. We have a lot of testimony from the field on how it's really helping them, especially during conflict zone. So we really like to thank Grand Challenge Canada for that. So thank you for listening, and hope you had a good.
It's Jan Hatcher-Roberts. Just before we start the questions, I just wanted to make 2 points I think that are really important to emphasize. And the first is that when Miriam talked about defining poverty at the community level and getting input in terms of the community understanding who are the most vulnerable, that really speaks to the concept of equity, i.e. a fair distribution of resources. And so it really brings into play how you can look at equity at any level to assume the fairness of whatever you're doing. And I think that's very important. The second point is what Patrick talked about in terms of the DHIS, the District Health Services surveys, and the fact that that gives you the important denominator in what we're doing. And so many programs deliver and count the amount of whatever service they've delivered, but we really don't know whether it's effective or not. So it's absolutely critical as we proceed in all of our work that we understand whether what we're doing is effective beyond the research part of it and moving into programs. We need to get a better handle on how we're doing in comparison to a reliable denominator such as the survey data. So I think those two are really important points that I think plague a lot of the larger scale programmatic responses. Thank you.
Wonderful. Thank you so much, Janet, Patrick, and Miriam. It was wonderful to hear more about how in the BornFyne project you are mainstreaming geo-information system data, and as well using it with a global platform like the DHIS. And so with that, we really thank you. But before we let you go, we'd like to ask you a follow-up question. Many of our members are interested in stronger evaluation methods to assess their activities. In your experience conducting a randomized control trial, which is considered one of the most rigorous assessments, and of course, within the added complexity of being in a fragile setting, could you speak to one challenge you've encountered with implementing RCT in BornFyne, as well as one strength or positive opportunity that has resulted from your RCT implementation?
Okay, thank you for that question. So this is a very good question, and especially in this conflict zone. So one of the main challenge, Patrick already mentioned something similar to that, which is striking the balance between programmatic and data strategies. And the challenge was to recruit in control, because you're bringing a development and now you need to recruit only more in the intervention for the development project, and then the control may not be getting this, especially in a conflict setting. So that was really a huge challenge. And also finding the appropriate persons to collect this data in such conflict and rural setting was also challenging. So one of the greatest tools that we use at this point was, first, in collecting this data, we actually did a lot, we invested a lot in capacity building. So we need to train data collectors in several aspects, reinforce their research strategies, and we made sure all data collectors went through the ethics course and they had to pass the course online. And we trained them on some of the tools we have just shown you, like MagPie. So investing a lot in these data collectors was one of the strategies that we actually used. And then the DHIS data also is a complementary software that you can use. Having difficulty in collecting data in the control, so we had to use that also, because it's a standard care and they're already collecting data in these health districts. So that's one of the strategies that we actually use to be able to get enrolled participants in the control group. And maybe Patrick would like to add a little bit more on that.
Yes. Also, in addition, working with the community is also something that is very important. We need to bring the community into the research. As you can see, to get to one of our sites, of our research sites, we had to cross like 3 bridges that are made up of just one stick all over the river. The stick is wet and you could easily fall off. Then sometimes we had to go through wild cattle and then find our way to find the participants that we needed to recruit. So all of this is not possible if you do not have community members who are able to guide you and take you around. So in this case, we had community health workers and traditional leaders who worked with us to help us to penetrate these areas where we needed to find the very poor people in the community.
Wonderful. I will ask another question. For members who may not have the capacity, which means resources or institutional support, possibly, to conduct a RCT, can you describe how you can or may already have supplemented within the BornFyne project this RCT methodology with either alternative activities or other evaluation/assessment methodologies?
Okay, so thank you. So like I highlighted already in the few of the answers before. So one of the strategies that we did use, like I said, is capacity building. So it's very important because we needed to train most of these people, especially in this challenging situation. And then for those who, in getting data, another strategy is also like using the DHIS tool. It was also a very strong strategy for us because you have the DHIS also collect most of the outcomes that we are also collecting. So it's something you can use also as a control, depending on how you design from the onset. So it's actually a perfect substitute in a situation like a conflict zone, like what we were experiencing. So especially if they have a completeness of data collection as well. And then one other important thing also is the fact that the performance-based financing program also has a good platform in, it has actually done a lot in helping to identify health areas, classifying them in some particular aspect that is easier for us to be able to pull in health areas that we want to work in. For example, if you look at the RCT design, we stratified according to equity scores. So the rationale for that is that we are actually targeting the very remote areas. So a high equity score already tells you that this is a remote area. So you just look at the PBF, when I say PBF is performance-based financing. So looking at their profile from a district perspective, you're already able to identify the specific districts that you can work with, stratifying them according to those equity scores. And then you can be able to now work with their district health information system. So maybe Patrick will want to add something to that.
Yes. So also in situations where it's maybe with the resources and everything, and we still cannot do these RCTs, there are also possibilities for doing other mixed methods. For example, even within BornFyne, we did a lot of qualitative evaluation, which could also give us enough about our intervention before and our intervention after. So observational approaches can also be used that could also provide you evidence that is as good in situations where you really are not able to conduct these RCTs. But again, that strength between the academia and the local organization is very important. For example, Miriam spent quite a lot of time here in Cameroon working with data collectors and training them on how to do this. And with this, we also worked in collaboration with the academia, and we kept close contact.
Wonderful. Well, thank you both for answering so eloquently these two questions for our members. We really want to thank you on behalf of CanWaCH for your time, Miriam, Patrick, as well as Janet, for sharing with us many of these fantastic and innovative types of activities you have undergoing at BornFyne. If you're watching this session and you'd like to know more about this BornFyne project, stay tuned for part 1 of the series found on CanWaCH's website, where Miriam and Patrick will walk you through more of their partnership building and navigations in conflict settings. So thank you very much, and we hope this was really helpful for everyone to learn more about. Thank you.